Dear colleague, we often face thought-provoking questions and dilemmas in our daily clinical practice. It's common to encounter differing opinions and approaches among healthcare professionals from various backgrounds. While it's important to appreciate their perspectives, we must also review what the evidence and guidelines actually say, rather than relying solely on verbal discussions. Above all, every piece of medical information should be interpreted within its proper clinical context. In this video, I will talk about the differences in managing small distal deep venous thrombosis compared with large proximal deep venous thrombosis, an issue that came up during a recent discussion with a vascular surgeon colleague. A 38-year-old man presented to hospital with swelling and pain in the left leg for the last few days. On examination, there was discoloration of left leg while comparing with right leg and calf tenderness was present. Deep venous thrombosis was suspected and confirmed. He was hospitalized and started on rivaroxaban 15 mg twice daily for 21 days and subsequently 20 mg once daily for total duration of 3 months as per guidelines. Patient was frequent long-distance flyer. On subsequent follow-up around 3 weeks later, he improved significantly and venous duplex showed resumption of flow in the obstructed vein. He was referred to vascular surgeon in view of associated varicose vein. Later vascular surgeon colleague discussed with me that since his deep venous thrombosis was only limited to intramuscular vein of soleus muscle, he could have been given either aspirin or half dose of rivaroxaban rather than full dose. This was something I was not aware of. So, I decided to check the literature and recommendation. I could not find any recommendation mentioning the use of aspirin or half dose of anticoagulation in this patient. So, can aspirin or half dose of anticoagulant in DVT given? What is the difference in medical management of small distal DVT versus large proximal DVT? Literature mentions that anticoagulation is the standard for proximal DVT, while management for small distal deep venous thrombosis is more controversial and depends on individual risk factors. For proximal DVT, anticoagulation is routinely recommended to prevent pulmonary embolism, but for distal DVT, the decision to anticoagulate is based on a risk assessment to determine the likelihood of clot progression, bleeding risk, and other factors, like cancer, with some guidelines still recommending anticoagulation for hospitalized patients with small distal deep venous thrombosis. The risk of pulmonary embolism from small distal deep venous thrombosis is lower, but the risk varies, and the clot can extend to the proximal veins. In low-risk patients, some guidelines recommend serial ultrasound monitoring instead of anticoagulation. Anticoagulation is initiated immediately, often with direct oral anticoagulants or initial heparin followed by a direct oral anticoagulant. Stronger anticoagulants are the primary treatment for an acute DVT. Aspirin is more of an extended or alternative therapy. For a small, isolated distal deep vein thrombosis, initial treatment with a half-dose, direct oral anticoagulant is generally not the standard of care. Current guidelines often recommend one of two primary approaches. If treatment is initiated, the standard approach is to use the same full therapeutic dose and regimen as for a proximal DVT for at least 3 months. This is often recommended for patients with severe symptoms, extensive thrombus, or risk factors for extension like active cancer, previous VT, inpatient status. Or for the low-risk patients with small distal DVT and no severe symptoms, the American College of Chest Physicians and other guidelines suggest initial observation with serial compression ultrasounds, for example repeating the ultrasound after 1 week. Anticoagulation is started only if the thrombus is found to extend proximally on repeat imaging. Reduced-dose direct oral anticoagulants, sometimes referred to as half doses, such as apixaban 2.5 mg twice daily or rivaroxaban 10 mg daily, do not have a primary role in the initial acute treatment phase of any DVT. Instead, low-dose direct oral anticoagulants are primarily used in the extended treatment phase, for example secondary prevention, typically after an initial 3 to 6 months of full-dose anticoagulation, for patients at high risk of recurrence but low risk of bleeding. In this specific context, studies have shown that reduced doses are as effective as full doses for preventing recurrence and are associated with a significantly lower risk of bleeding. To conclude, there is no role of aspirin or half-dose direct oral anticoagulant in the acute phase of DVT irrespective of the size and location of DVT once treatment is initiated. Even if treatment is not initiated as an acute small distal deep venous thrombosis who does not have severe symptoms and/or not at a risk of recurrent or extension of thrombosis and undergoing follow-up imaging, there is no role of aspirin or half-dose of direct oral anticoagulants. If it is decided to start treatment for acute DVT in such patients, it will be full-dose direct oral anticoagulation only provided there is no limitation to therapy. Aspirin can be used as an extended therapy after 3 to 6 months or as an alternative therapy rather than the preferred or primary therapy. Similarly, half-dose direct oral anticoagulant can be used as an extended therapy after 3 to 6 months in those patients who are at high risk of DVT recurrence and low risk of bleeding for the purpose of secondary prevention. I hope this information was useful to you. Write me in comments.